Sawyer from Orthopedic Surgery at UCSF, and I wanted to talk to you today about bone health. And it's a little bit different perspective than you usually hear about it in. I like to talk about bone health across the lifespan. Because we get one skeleton, carries us through life, and the stronger we can make it in the beginning, the more we're going to get out of it at the end, and you'll see what I mean by that as we go along. I also have a couple of different roles. I'm directing the development of the Skeletal Health Service at UCSF, and I'm also the Associate Director of Digital Health at CTSI, so there's a little bit of technological stuff at the end. In case you wanted to go to both sessions, you can have some technology and bone health altogether. So basically, I'll tell you a little bit about osteoporosis. Some you've probably heard, and maybe some you haven't. I'll try to not go too heavy into the details of the science, because basically I want to get a message across that's practical, something you can walk away with and make some changes. I usually start, and also tell you some local resources. I usually start by asking how many people in the room have had a fracture? Yeah. And how many people, so HIPAA compliance out the window already. How many people have children? Great. And grandchildren?
Step.
Yep. How many people have bones? I think I've got everybody. Okay. So there'll be information on each of those topics for you here today. I'm going to talk about osteoporosis with its new definition. It changed in the last 10 years. Instead of just being about bone density, it's now about including other factors besides density, microarchitecture, geometry, shape, and size. And that we'll touch a little bit on. We'll have a tiny bit of science, not a lot, but enough, because most people nowadays especially want to know more and more and more about their bodies, and the information is ubiquitous on the internet, so sometimes it's hard to decide what's the right information. So we'll get into some of this. Most people are familiar with the look of this, which is normal bone, and this is actually the cancellous bone. If you saw a cross-section of a bone on your dinner plate, the outer ring is the cortex, and the cross-sectional part, or what I call the honeycomb look, is the cancellous bone. That bone turns over a lot faster. What that means is bone is constantly being resorbed, like broken down, and built. It's a coupling process that goes on through our whole life. When it's being built more than broken down, we end up gaining bone, and vice versa. But this bone turns over very quickly, so it's a hallmark or a canary in the mine of when there is a problem with bone being resorbed too much or not built enough. It also shows you that there's a tremendous amount of complexity to the arrangement of bone. And the beauty of bone is we can actually train it or direct it how to grow and how to support us better, and you'll see more examples of that. So if you look at this is a vertebral body, which are the building blocks of the spine. In young people, you can see the struts are oriented really vertically because we take load that way in our spine. And as you can see, that's quite a bit denser, a lot more of these struts, the number, the orientation, the thickness of them, a lot more than you see in the lower bone in the vertebral body. And most people can see that there's a change in all of these parameters, so that's why the definition got broader for osteoporosis. And the idea is really, how can bone withstand load without failing? And that's really the fundamental reason we care about all this, because fracture is the thing we care about. Most people have seen this diagram in many different versions, and what it's actually reflecting is microfracturing and sometimes full fracturing of the vertebral bodies, and they're collapsing, and it can even be silent. So you'll see that height becomes a really sensitive indicator of whether you might be having fractures and have low bone mass. This just shows you a little bit about geometry. If you start, this is women, men, starting way over here at birth, the bone not only gets denser and more mineralized as we grow, it changes geometry a lot. So in kids, if you look here at puberty, it's starting to get much bigger. If you imagine this as your femur, the diameter gets bigger, which allows it to withstand more load. The thickness of the bone gets a lot greater. As you get way out into older years, you start losing bone mass, and the body compensates in an interesting way. It's losing bone around the inside, but it's adding bone to the outer ring. Men are more effective at doing that, so they get more protection longer than we do. But it's a way to compensate. You can either have diameter or thickness, and they both play into how strong the bone is. So that's just some more about the compensation and the ability of bone to change. This shows you a 20-year-old bone, and this is, people probably recognize this as the hip joint, and this across here is the neck. This is a 20-year-old, here's an 80-year-old bone. Two things about it, the inside is really, really disappearing. The outside is also getting very thin, the cortex. And what you can't see very well here is it's actually very porous, so it's not very good at withstanding load. Even though it's trying to expand a bit, that's not making up for the amount of internal structure that's being lost. So you know we have an epidemic of this in our country, and I won't read through all the numbers, but it's actually increasing dramatically. You've read some studies about hip fracture rate going down, but the absolute number is going up because we have more people getting into an age range where hip fractures are more and more prevalent. And so one thing we don't talk about much, and I'll talk about several times, is men. We think of it as a postmenopausal women's disease, but there's a big burden coming in the amount of men who are aging. The good news is, as we age, our generation of baby boomers are more active, so hopefully that will give us some protection. In other ways, it adds more risk, as you see that fall is a risk, as well as whatever condition your bone is in. Fall can be an independent risk factor for fracture. So looking at this with something missing. This is transferred from a PC to a Mac version of PowerPoint, so a few things drop out. Sorry. But what was here was heart disease, and where those two stars are is about the top. And I use this slide because I think it's fascinating to look at. Heart disease, stroke, and breast cancer combined don't make up to the number of osteoporotic fractures we have in our country. Most people say, well, those are more severe conditions. They often end up with people dying. So if I could point out to you, osteoporotic fractures also have a really high mortality rate.
There it is.
Oh, hi. So they have a very high mortality rate. 1 year after hip fracture, it's estimated that 20-25% of people will not survive 1 year after a hip fracture. It's actually much higher for men, and you'll see that coming up. Permanent disability in a third of the people who came in walking independently, 40% are unable to regain that status again in the present way that we take care of them. And then 80% come in at least 1 or 2 levels down from their prior level of function. So it tells me, I was a physical therapist for 10 years before I became an orthopedic surgeon, and it tells me we need to really focus on how we're doing in managing people pre and post-op in the fracture care so that we can change these numbers, and then we've got to back up another step and prevent them. And then when we're facing a fracture, we got to prevent the next fracture. So that's the way I look at this, and that's where it comes across the spectrum and actually backs way up into childhood. Vertebral compression fractures, most people think of them as no big deal. Oftentimes you don't even get hospitalized. Sometimes you don't know they've happened. The truth is there's a high mortality rate with them because as you collapse your spine, usually they collapse in front first and you get a wedge deformity. As you go more and more into this position, you can imagine what's happening to your lung volumes. It's really decreasing. So pulmonary failure is a problem. I keep looking at you. And then the other thing is you can't eat as much. Your abdomen gets compressed. It kind of protrudes out a little bit, as you can see in the lower diagram. Truth is, you can't take in as much nutrition. So it's just what we call kind of a downward spiral when you start getting vertebral compression fractures. And the other really key thing is it's predictive of future fractures. Hip fractures, spine fractures, even wrist fractures predict that you have a higher risk of future fractures. It's another reason we need to take them more seriously and look at the underlying bone problem rather than just the fracture. So a lot of people also don't think a wrist fracture is that big of a deal. I have many friends who tell me, I just had a wrist fracture, and I'll say, did you get a DEXA? No, so it's just a wrist fracture. So I want to bring out the fact that even wrist fractures carry quite a bit of morbidity. So consequences that are long-term. 50% of people at 6 months don't have a very good functional outcome. 30% are never at the function that they were before. So it is a big deal. But again, one more thing about it is it's a precursor. It's an indicator and a risk for future fractures. And here's just a quick diagram of that. If you look at forearm fractures in women, it tells this is the lifetime risk of having fractures. If you look at women and men and you combine the types of fractures they have, for women, 50% of women over 50 are predicted to have a fracture sometime, and they have a lifetime risk of 50%. And men, it's about 30%. So as we do this, we also are constantly trying to change those numbers. We look at those and we say, can we make that better? What are we missing here? So there's a major focus on osteoporosis in women, but I think it's time